So I'm really happy to introduce Dennis Dix. In addition to directing the Access Center here at Kennebec Behavioral Health, Dennis Dix, who is an LCSW, teaches sociology and psychology courses at a local community college and provides field instruction to MSW graduate interns. His research interests include barriers to treatment, continuity of care issues, burnout in the field of social services, access to behavioral health and substance abuse care, effectiveness of case management techniques, and post-traumatic stress disorder. Captain Dix accepted a direct commission in the United States Army Reserve Medical Corps in 2007 and has been granted credentialed privileges at Fort Drum, New York, Camp Keys, and Augusta, Maine. He most recently returned from a tour in Afghanistan where he was officer in charge of a combat operational stress team. Welcome, Dennis, and thank you for being here.
Thank you very much. Tina and I actually just saw Senator George Mitchell present a little presentation and talking about his book on a book tour in Augusta, Maine. And he drinks hot water before every speech that he gives, a tip that Ronald Reagan and Frank Sinatra gave him, I guess. So I'm drinking hot water to sort of relax my throat. If my voice gives out, you can thank Senator Mitchell. There it goes. So today's presentation is Access to Care. I'll go through and use the PowerPoint as a kind of a launch of material, but I'll try to avoid reading the PowerPoints to you just because I'm not a big fan of being read to. And some of these slides will go through a little quicker and basically give you an overview of the services that we have at Kennebec Behavioral Health, some of the issues that we face, barriers to treatment, and the algorithm, if you will, of how patients and referrals access care from the community. A few objectives that we'll cover today. As I mentioned, if we go a little bit deeper with certain topics, some slides might take a little longer. It's an average of 30 seconds a slide, I guess. The big one will be to show you some of our new products that are designed and intended to reduce time to service for people seeking treatment here. A couple of models which I'll show you as a reminder. So as a teacher, I couldn't resist using some theoretical models. We are helping folks sort of navigate through macro and micro levels of systems. So we have individuals that have symptoms and difficulties, and they're trying to get through sometimes a very complex system of variables just to get help. And so our Access Center specialists are trained in helping individuals navigate that system. Most of the work that we do is by phone, and I'll get into that in greater detail in a few slides later. And we also stay very mindful of Maslow's hierarchy of needs. So sometimes we're dealing with folks that are just struggling with getting health, food, and sleep. That's the basic foundation of the pyramid. Some folks are in shelters or in situations of danger or in need for removal of a dangerous situation. And so we're there to help with that as well. We don't necessarily do that directly, but we will help people get to the right service or the right level of care. Basically, think of Access Center as a triage unit in a hospital. We look at time-driven events and event-driven circumstances. So a time-driven event, what we're looking at there is time to service. How long does it take for a client to actually call us, and from the point of that first point of contact, the call, to coming here and actually receiving care? That's a measure of our success. Right now, the average is about 14 days, which is too long in my opinion. We're trying to get it down to 5. That's our goal. Show rate, so sometimes people have difficulty actually showing up to that first appointment. And there are a number of reasons for that. Some of you may be aware of transportation difficulties, weather. You know, we're in Maine, northern state, a lot of snow, and I guess the Farmer's Almanac is predicting kind of another tough winter this year, so we're ready for that. And event-driven is sometimes people don't call, they just show up, or they might be getting discharged from a hospital, psychiatric hospitalization. And that discharge isn't always, there isn't always a lot of time to prepare for that discharge. So we're prepared to react to hospital discharges in a way that will get somebody discharged from a hospital and then seen for outpatient care with relative quickness. This slide might be hard to appreciate because of the print. I have another slide of Somerset County, which is a little bolder, but basically this slide is intended to demonstrate the way in which Access Center operates across our catchment area. So we have Skowhegan circled in red here, Waterville, Augusta, and Winthrop, our 4 core service office locations. We have, and I'll get into this in a minute, we have community-based services which reach much farther beyond this, but these are our core services and our 4 main office locations that offer med clinic, outpatient, and substance abuse treatment. Think of traditional outpatient mental health services or behavioral health care. And these blue lines represent how someone from anywhere in our catchment, or really anywhere in the state, can reach an Access Center provider in any one of these 4 locations. We're all tied into the same phone system. It's called an automated call distribution system. And that's what we do. We run a call center. We stay in touch and talk to each other and have our team meetings, oftentimes using this very television screen. We all can link into the same meeting by using this TV screen. We can all see each other and hear each other. And this represents sort of what we're looking at for the landscape of Somerset County, which has a little bit different kind of issues or barriers to present. The population density is much different in Somerset County. It's about 50,000 versus Kennebec County, which is 120,000. So as you know, the roads can take a beating here because of the solvent that's used to melt the ice that gets really thick in the wintertime. That can chew up your vehicles, and just in Maine, and particularly in northern Maine, we pay more for gasoline and heating oil than just about anybody. So as you can imagine, there are economic barriers that can contribute to depression. And one doctor told me one time, I don't know if I get to say this and tell you that I made it up, but the doctor said, we're all vitamin D deficient because of where we exist on the planet and how the sunlight hits our planet. So, so you don't have to take it from me. You can Google that or look that up to verify. A lot of what we're trying to do in Access Center is test. We test a lot of products, we test a lot of ideas, and we basically run through our systems using a walkthrough process where we act as if we are the client seeking care. So in that way, we can appreciate how people come to our agency. What is the parking lot like? What is the waiting room like? How long are we on hold when we make a phone call? Those types of things. And by doing that, we're able to look at areas for improvement. And once we identify an area that needs improvement, we start to make small adjustments over about a 3-week period of time to improve whatever barrier we've encountered. If maybe somebody is on hold too long, and so we'll try to figure out a way to tweak the automated call distribution system so that we can respond to those calls a little quicker. Again, our goal being to reduce time to service and also to be there in those cases where sometimes people wait a while before they're ready to pick up the phone and call us. And so our Access Center specialists, really all of our clinicians too, have a skill set that includes a way to catch the person that's finally reached that point where they're ready to make the phone call and ask for help. This slide demonstrates how people come to us. If you think of a continuum of care, as I mentioned before, sometimes we get folks that are in the hospital. Sometimes we get referrals from our local Department of Health and Human Services. working with families or working with somebody experiencing homelessness or things. And so those professionals, those state departments all have the ability to call on behalf of their clients to seek care. And then, of course, anybody, most of the referrals we get actually are from self-referrals. Folks that are calling themselves to ask for help. Everyone that comes here participates in what's called an initial assessment. For those of you that have been around a little longer, you might have heard us use the language intake. So we're going to schedule you for an intake. We've changed that language a little bit to include a more holistic assessment. Immediately following that assessment, we perform some rudimentary or initial treatment planning, including service plan modification, which will vet the person to the proper level of care. So for example, if someone comes to me and they're seeking med clinic because they need a particular medicine, antidepressant or an antipsychotic, I will perform the initial assessment, render a diagnosis, and then as part of the service plan modification, set them up with a referral for one of our psychiatric providers. If they're eligible for other services or interested in other services, I'll set that up as well, right then and there. Then, of course, we have the treatment phase and aftercare and discharge planning. We're really big on evidence-based practice. I have some handouts that I will show you in a minute as we go through the slides to demonstrate to you or to show you how we demonstrate our progress in treatment. The very first thing we need to do is establish a baseline. So by offering psychometric measures, we establish, how much sleep are you getting? How is your mood doing? Or in cases of substance abuse, how much are you using or how much are you craving? It's good to know that right off the bat during that initial assessment so we can go back and look at that data comparatively over time as people are receiving treatment to see how they're doing. These are the various types of treatments and services that we provide. Medication clinic, as I've already mentioned, and substance abuse and outpatient, also already mentioned. We also offer in-home and community-based services, as do other agencies in this county. If we're at capacity and we can't help you, but you're calling us for help, sometimes we're able to know who is taking new patients, and we'll share that and get people to the right level of care based on other agencies or our capacity. And we try to give people an idea of how much time it will take to get into a particular service if there's a wait time. Sometimes we can offer other services or offer other locations, as I've mentioned and demonstrated on the map in the earlier slide. We also offer psychoeducational and psychodynamic groups. So how do we know if we're being effective? Some of this language is a bit technical, but and that's why I've given you some handouts. If people are interested in receiving material electronically, I can also collect email addresses and send you these things electronically as well. The first one is called the Outcome Questionnaire 45, or we call it the OQ 45. We also use the Beck's Depression Inventory and the PCL-17, which is a post-traumatic stress symptom checklist. Not everyone uses self-anchored scales. That's up to an individual clinician. Excuse me. This is just a picture of what I've just handed out. This is 35 of the 45 questions. And you'll see as you go through some of the items, there are some red flag items here. For example, item number 8, I have thoughts of ending my life. Very important for me to understand coming through the door if somebody answers almost always, which would be a 4 on a scale of 0 to 4. for suicidal thinking. Here's a close-up of the top 10 items of the same questionnaire. And I don't have a sample of the Beck's inventory to give you, but I do have a sample of the PCL, which I have also passed out. And that has the watermark sample on it as well. People familiar with the term PTSD, post-traumatic stress disorder? You might recognize some of the items there that are intended to establish the baseline and tracking progress for specific symptoms for post-traumatic stress. If I'm tracking somebody's anger, that's good to know week to week. So sometimes after I do an initial assessment, I will personally see a patient after the fact. And particularly, I'm kind of a PTSD guy and an anger guy. So I use this a lot. And I might say at the end of an initial assessment period, we're going to get you an appointment for Med Clinic, or we're going to get you to the right service, but I think I might be able to work with you on the anger. And why don't we make an appointment right now, and I'll see you next week. And then when I see them next week, I'll want to know how they're doing on a scale of 1 to 10, for anger. I won't give an OQ every time. Typically, we give an OQ 45, that first sample metric that I gave you, every other week. So it's about 14 days of data. And we have some other things that will help people track symptoms on a daily basis. Often a mental status exam will help us establish the baseline and how people, again, are doing from the time they start treatment until the point of discharge. We're looking for remission of symptoms, intensity, frequency, and duration of symptoms. I added this slide, just some of this was, as she mentioned, while I was in Afghanistan. And I did a lot of the same work, and some of the ideas that I got for building resiliency and utilizing strengths, I was able to apply on my own and learned, and then brought some of those ideas back into the care that I provide. We identify strengths as part of the initial assessment. This slide represents the trajectory of some of our psychometrics. So the OQ45 in particular will allow us to, over time, not only track your progress, but also predict positive outcomes for treatment, to the point of including how much treatment will be needed. So oftentimes I'll get a feedback message that says, it looks like you're doing well, you're heading in the right direction, and you might need 5 more sessions, and we can talk about discharge. If we're not heading in the right direction, then we'll talk about that. Maybe it's something about the therapeutic relationship, or maybe there's some cravings that are going on that I wasn't aware of during our conversation, but we were able to pick up during the screening. How can we participate in the care of an individual in a way that initiates care, provides the right amount of treatment, and encourages effective and meaningful aftercare planning, including reentry into care? I've already mentioned some of the ways that we do that in terms of analyzing, discussing, researching, and reanalyzing our processes and our process improvements. We use undergraduate and graduate interns a lot. We have one that started a couple of weeks ago, Derek. So, and he'll be working with the AmeriCorps group and some other partners in the community. SCARP is the Somerset County Association of Resource Providers. Anybody here a member? Rob Rogers is the point of contact here for that. And Tina and I can also assist you if you want more information about that provider group. Rob also is participating and facilitating Somerset County Law Enforcement Task Force. With Derek's help and possibly with AmeriCorps, Tina and Liz and I will talk more about this later. We may be looking at starting a main military community network out of Somerset County as well. I believe that we can do better. My goal this year as Director of Access Center is to improve the relationship with our community providers, including our state departments, Departments of Human Services, Health and Human Services, and Departments of Corrections particularly, but also the Department of Labor. As I've mentioned, there are several ways to access care through our services, and we have a new product now based on our website, which I will give you. And there are two ways in which folks can refer on the web. One is as a professional. So they're basically, think of this as two doors to making a referral. Folks can go here and make referrals for themselves or for family members. That's highlighted in blue and checked off in red. The green highlight just below that is for professionals who wish to refer their clients and patients to our services. We believe that this platform compels a completeness to the referral. So we need so many data points in order to open up a case. And by offering this platform, we basically are giving you the script for the data points that we need in order to initiate a case. Oftentimes, if we don't have the right amount of information, that case can get hung up as an incomplete referral, and it protracts the time to service. Remember, our goal is to march it down from 14 to 5 days, and we believe that this will help us. So our students help us product test this. Our professionals who use this platform, if they notice a problem, they're invited to call us, and we get our students walking through to see if they can duplicate that problem. And then we are able to work with our own IT department to fix that problem. In the meantime, we're also aware that there's a referral being made, so we don't let the computer hold up the referral process. By being aware that there's a problem, we can actually act much more quickly and get the information that we need in other ways. Here's the web address for our website. And remember, folks can self-refer or professionally refer their patients and clients. Thank you very much for giving me the time to present Access to Care today. It's been an honor to speak to you about the services in this community. I look forward to working with all of you. Thank you. I'm really glad you asked that question because that's something that I have heartburn about. Sometimes we run into that as a potential barrier to services. One of the reasons we have an internship program and actually started that internship program was to be able to provide individual therapy under kind of our training, using our systems and our philosophies to provide care. We also have, for certain folks that meet criteria, we have outreach workers. So I'm talking out of both sides of my mouth potentially, excuse me. So we have graduate foundation students, first-year graduate students that can do outreach types of work. We have an outreach program where people actually work here in that outreach program. That's grant funded through something called the PATH, P-A-T-H grant. And then the outreach worker will connect folks with services and or help them seek entitlements. So if they're main care eligible, they can get insurance. If they're not main care eligible, they can start identifying what services are either providing leveraged care, excuse me, what programs or agencies are providing that, or who is providing grant-funded care. KBH, for as long as we have graduate advanced students, will be able to provide some level of outpatient care. Now, I'll talk out of a third side of my mouth and say, for somebody that's homeless, we're not really ready yet to take somebody like that on and provide insight-oriented therapy. But we may be able to provide some supports or some coping. Some of them might be limited in terms of what we can do for that person until a home is established or some secure shelter. Does that make sense to you? Did I answer your question? Good. Yes, potentially. Are there other issues? We won't get into it, but I could say anecdotally, if there are other issues that would prohibit, we would look at those cases on a case by case. And if it looked like they were there and stable in terms of being caught there and not going to move anytime soon and things, then we might be able to provide something to that person. And it depends really on what you're looking for, or what the patient is looking for. There's also a timing sensitivity. So my intern that's starting in September might not be spun up with all the skills and everything, even just how we use our computers, until October or November. So sometimes there's a time sensitivity around that. And I say that with some heartburn because, again, talking out of both sides of my mouth, our goal is to reduce time to service. So ideally, I've always got a foundation year intern. I've always got an advanced year intern. Maybe there is a role that the AmeriCorps volunteer community health worker could play in terms of identifying the needs and helping us with some of that assessment if we can't get out there to assess them. So just now I'm just thinking off the top of my head and being creative, but I think that that's probably what we need to do in order to reduce that time to service and get some help to your folks. The key, I think, for you, the takeaway would be register for the web base. Mm-hmm. If you register for the web base, you'll see a much greater reduction in time to service just around the data point collection. It'll be a faster track to the complete referral. Demographic. Okay. It's mostly demographic. And then with for the self-referral, we try to keep it fairly basic. With the professional referral, we might get into more specifics about the types of service that's being requested or some types of issues that are present or symptoms that are present that compel the referent to make the referral in the first place. If there's time, well, okay, let me go further and say we also offer some individual tutorials. So if people get stuck and they want to make a lot of referrals using the professional side, we have, again, our interns that are trained up in doing that. They can make arrangements to come out to people's offices to walk through and show them how to do that. And we also provide some, limited of course, but some telephone support around questions or barriers with completing or registering for the web-based.